All right, a very good morning to you. It's good to see you this bright morning. It's actually quite bright. We are in a totally different location. We're not in studio, but we are at the largest referral hospital also in East Africa, all right? And that is at Kenyatta National Hospital. And it is Breast Cancer Awareness Month. And we are here today. If you've never been in a theater, well, today we'll give you a glimpse of what exactly it looks like. And I must admit, I came here and I'm feeling some type of way. But that's besides the point, okay? So we're talking about breast cancer. And today we'll be focusing mostly on breast cancer treatment and care, all right? And there's so much that we need to discuss as far as breast cancer is concerned. It's not the first time that we're talking about it, but the biggest question is, why is it still a big burden right here in the country? What are some of the current trends and the treatment options for the same? You want to stick around until the end of the show. But if you are a breast cancer survivor or a warrior and you're watching us this morning, feel free to call in live and share your story with us. If you want to celebrate a breast cancer survivor, feel free to do so as well on our socials, and that is at NTV Kenya, both on Facebook and on X. But to help us with the conversation this morning, I am joined by Dr. Eric Hungu, not a new face, maybe to some of you, who's a general and breast surgeon right here joining us this morning. Thank you so much, Dr. Eric, for making the time. And we also have Dr. Sitna Mwanzi, who is a medical oncologist. Good to have you on the far left. And we have Eunice Wanjira Njaramba, who's a breast cancer survivor, here to share her story with us this morning. But Dr. Sitna, let me just begin with you. So breast cancer, this is not the first time that we're talking about it. We have had so many conversations surrounding the same. What is the current burden?
So thank you for hosting us. Breast cancer is still the most common cancer that's diagnosed worldwide. Okay. It's also the most common cancer diagnosed in Kenya. About 25% of all the cancers will be breast cancers in Kenya, followed closely by cervical cancer. So you can see that the cancer burden in women is very high. Mm-hmm. So the cancer burden is still high because we are in Kenya, it's kind of difficult to know the exact status because we know that many people go undiagnosed still. So we are probably missing out quite a number of women being diagnosed. Mm-hmm. The other difference in Kenya is that we see very young patients. We see patients as young as 25, whereas in the West, majority of the patients will be over the age of 50. Mm-hmm. And if you look at what are some of the risk factors, most of the time it's related to hormone exposure. Mm-hmm. So women obviously will have more estrogen compared to men. They'll have, so the issues around, fertility and kind of things. But there are things that we don't know. For example, what is the genetic makeup of the breast cancer in Kenya? Mm-hmm. So why are we getting people who are 25 or low age getting breast cancer? So there's still a lot of unknown about our own breast cancer. Mm-hmm. The other thing is majority of our patients come when they're in advanced stages, so stage 3 and 4. And there are multiple reasons for that. One, we don't have an organized screening method so that you come to the hospital before you get any symptoms to have screening done. Many people are still struggling to seek healthcare because of out-of-pocket payments despite all the advances with NHIF. And then there's also the fear from the community, like every time someone hears, I have cancer, they equate it to death, yet we know that there are very many people who can survive cancer like our survivor here.
Yes. Yeah. And we're so happy that she's here really to share her story. But before we talk to Eunice, very quickly, on the men, because the reason why I'm saying it's so weird that we talk about breast cancer almost all the time, but there's still a lot of misconceptions surrounding the same. And one of the things is men. Okay, because we're having a conversation one time in our office and people ask, but men also get breast cancer? So can we talk about the burden then when it comes to the men? And first of all, do they get breast cancer?
Yeah, actually, men do get breast cancer. Mm-hmm. Like Dr. Sitna said, the risk factors are usually hormonal. Okay. So, of course, men will be at a lower risk of getting breast cancer, but some will still get breast cancer. So the incidence is usually about 1%. Mm-hmm. And that's why we usually don't have like active screening programs for male breast cancer. Right. And again, because of the reduced volume of breast tissue, what we usually suggest is that, just like with the ladies, we should all be aware about what's normal for us, what's not normal for us.
Okay.
Because it will still present the same way. Most times it will come as a lump.
Okay.
And by the time the men come to us, sometimes you find that the lump is quite big. They've been ignoring the symptoms.
Yeah.
And then when it becomes a little bit inconvenient or it's progressed, then that's when they come to us, to hospital. But men can get breast cancer. They need to be aware that that can happen. So if they see anything unusual going on in their breast, they need to come to us.
And check. So we know for the women, it's usually a lump, and we're told, feel your breasts. You will feel a lump that is quite hard, because there's so much happening in the breasts, right? So for the men, I'm just curious, what exactly does that look like? Do you also feel a lump?
Yeah.
Because women have a lot of breast tissue, no?
So it will be easier to notice it in the men because they don't have so much breast tissue.
Right.
But it will still present as a lump. Mostly it's a painless lump. By the time it's becoming painful, it probably means that it's progressed, it's complicated, it's probably ulcerated.
Okay.
And when it's ulcerated, it gets an infection, then that will cause some pain.
Yeah.
But for the ladies, other than just looking out for the breast lump, there are other things that they need to look out for.
Okay.
So that's why we always suggest that they need to be self-aware of their normal anatomy, their normal, how it usually looks.
Okay.
And the breast self-examination. Yeah, so that means every month you check how is it looking, is there any nipple changes, any skin changes, such things.
All right, and we'll talk about when exactly then do you need to do self-breast examination, because, is it before periods or after? But let's speak to Eunice very quickly. So Eunice, let's go back to 2016, all right? Something happened. You felt a lump, and you went to get checked, and you were told, there's nothing serious, you're okay, all right? Can we go back to 2016?
Thank you for having me. Okay, in late 2016, I felt there was something abnormal in my right breast.
Okay.
So it was a small lump, but I saw it was not something normal because it was not there before. So this a friend nurse of mine, I consulted, I talked to her, then she advised me I can go for a mammogram.
Right.
So I went in one of the hospitals in Nyeri. I was done the mammogram, then the results came that it was negative. He told me it's negative.
Okay.
So I went home. Then after that, maybe in 2017, I could feel the lump was it was becoming bigger. So, okay, there was a problem because there was also a problem of finances. So it's like I wanted to have a second opinion, but I was somehow limited. But when I realized it was now enlarging, I consulted another, a relative, a nurse also, who was here in Nairobi. And she advised me to come, that is, we came in 2018, October month, when the whatever is subsidized. So we came, then we were able to go to Aga Khan. I was done the mammogram. Then they found that there's something that was not conclusive. So I was also taken to the ultrasound machine. They also checked. Still, it was not conclusive. So at last, they gave me another letter so that I go and be done the ultrasound guided biopsy.
Okay.
So when that was done, the results came that I had, it was cancer. I was given the results. So that's when now we had to look for a doctor. And she recommended, she was helped by someone else that we were recommended to see Dr. Hungu. When we went to Dr. Hungu, he was so helpful. The way he attended to us, we got hope. There was hope. So from there now, we started with him. We went through, he advised us, and he suggested for us the best thing at that stage, because we were told it was in stage 2. So he advised us that the best thing at that time was to do the surgery to remove the breast.
All right.
And so that's where we started.
Yeah, I see that. So before we get to the treatment part of the same, so how is this possible that, one test shows negative and the other one shows that, she has cancer? It was what, at stage 2?
Yeah, at stage 2.
All right.
So it probably will not show negative.
Okay.
So what the recommended imaging modality for ladies over 40 is usually a mammogram.
Mammogram, okay.
But you know, a mammogram, the reason why we don't do it in ladies who are below 40 is because of the density of the breast tissue.
Okay.
So younger ladies have more dense breast tissue. So when you do a mammogram, it might not be very revealing, and especially in like early stages of cancer or like the precancerous lesions, like the ductal carcinomas in situ and such things. So she said it was inconclusive. So on the mammogram, they'll probably say this is a BIRAT 0, an inconclusive assessment.
All right.
So then for us to be able to make a decision one way or another, then you need to do a complementary ultrasound.
Okay.
So when you do the ultrasound, again, sometimes it might not show too much. It might just show some things there, like some slight changes in the appearance of the breast tissue.
Okay.
We usually call that some architectural distortion. So when you look and you compare with the normal beat, you can see that there's an area that doesn't quite look normal. But those two usually are adequate to come up with at least with an idea of what's happening.
Right.
If they're not conclusive, then we can do an MRI.
Okay.
Yeah. But once you see something, then the next thing usually is to do a biopsy. So sometimes you can do a biopsy in the office or in the minor theater, but most times you can do what is called an ultrasound-guided biopsy, which is what she had. And that can be more accurate because you're actually doing it in real time. As you're imaging, you can see the abnormal area, and you're actually targeting it with your biopsy needle.
Okay. Yeah. Dr. Sitna, most of the time when we talk about symptoms, the most obvious thing that people would think is a lump, right? But what are some of these other symptoms that we should be on the lookout for?
I think one of the things that can be confusing sometimes is skin changes. Sometimes you can notice that the skin is red and it looks like it's infected. And that's one of the types of breast cancer called inflammatory breast cancer. It looks like it's an infection. And then people are treated many times with antibiotics and it's not improving. And that can be also difficult for us as clinicians to diagnose because sometimes there's no lump underneath it. So it's just skin changes. So when we do a biopsy for that, we'll do a skin punch biopsy to diagnose that. Another thing could be the nipple retraction, the nipple going in. So most of the time the nipple is outward, going in, or a nipple. Ignore nipple discharge. It could be a clear discharge, it could be a bloodstained discharge. Any discharge needs to be evaluated. Some people don't even have a lump inside the breast, they'll have a lump in the armpit, which is the axilla, and the lump could be part of the breast that is in the axilla, or it could be the lymph nodes that are in the armpit that actually start off as cancer. So there could be varied presentations. Some people actually present when the cancer is more advanced, so they'll have other symptoms such as cough, difficulty in breathing, bone pain, abdominal pain when the liver is enlarged. So you could have a wide range of presentations. Some people come with a headache, then you find that they have the cancer has spread to the brain. So you could have multiple ways in which patients will come the first time.
Okay.
Yeah.
All right. And they say what 60, is it 60, 70%, 70, 80% of people come when it is at the later stage, and would want to understand why. Is it because the symptoms then mimic other symptoms that sometimes it's very easy for people to ignore?
I think that there are multiple reasons. There are some factors that are related to the patient. Like Esther has said, like if you don't have money to go to the hospital, so you felt a lump, but you don't have money to go to the hospital, you don't have money to do the test, that can delay the time for us to diagnose you. And sometimes you can go to the hospital. For example, a common thing that happens is if you have a pregnant or a breastfeeding woman and they have a lump, they're told that this is related to their pregnancy, yet this could be cancer. So any lump, whether pregnant or breastfeeding, needs to be evaluated. So there are also system factors, like in the healthcare system. If you're coming from a place where there is no healthcare facility or a doctor who can examine you appropriately, and then you have to be referred to the next level of healthcare. So there are also those barriers in terms of health system referral. Yeah. And then some people will just come with stage 4 cancer, not because they have delayed anything, but because that is an aggressive disease that they have that can present in the later stages. Okay. Yeah.
All right. And Eunice, so the doctor says you have breast cancer, right? What is the initial thoughts, that comes to your mind? And how much information did you have, first of all, as far as breast cancer is concerned? Because you told me your case was not the first case of cancer in your family.
I actually panicked, and not only me, but even my family members, because we had experienced some some not so good experiences in the past. I think I had mentioned that my dad had passed on through breast cancer. I had also lost a sister through colon cancer.
Okay.
A sister-in-law through breast cancer.
All right.
So when I was told I have cancer, I was shocked.
Yeah.
But I had support of friends and family. I remember this, my pastor. My pastor came at the right time. Actually, immediately I was given the results. They came with the wife and they really encouraged me. And they showed me cancer is not a death sentence. And from there I started confessing and saying I will not die. I will live and declare the goodness of the Lord.
Yeah.
So from there I had a positive attitude. And together with my family, they stood with me. My daughter and my son have never left my side. Doc is a witness. So I have had people who have really supported me, and from there I've been able to know that I can go through it victoriously and that I don't have to die from cancer. I can survive, and I've seen it.
Okay.
Yes.
All right. I see that, and we'll talk about support again before we end the conversation. But I know there are other risk factors that we did not talk about, and one of the things is breastfeeding. There's also a lot of conversation around contraceptive as well. So do you want to just make it clear for people to understand how that then either puts you or does not put you at risk of breast cancer?
So like Sitna said, usually it's related to hormones, so the female reproductive hormones.
All right.
So mostly it's estrogen that's implicated in the pathophysiology and how this disease will come about.
All right.
So then that conversation about contraceptives, it is a risk factor. It has been shown to be a risk factor.
Okay.
And it's usually the contraceptives that contain estrogen.
Okay. Because I was about to ask which type exactly, but yeah.
The one that contain estrogen.
Okay.
And then about breastfeeding, so it had been shown in studies that ladies who have not had babies, who've not breastfed, have a slightly increased risk of developing breast cancer.
All right.
So the physiology, the theory behind this is because breasts undergo various stages of development.
All right.
So of course they start development while still in the uterus before the baby is born.
Okay.
So when all the organs are being formed, so then they'll be formed and then they'll get into sort of like a latent phase. So that now when babies are born, male and female, anatomy looks the same.
Okay.
And then at puberty, of course now when the ladies now start getting their cycles, then they start getting the cycle, the female reproductive hormonal cycle.
All right.
So then that will cause the breasts to develop now, so that now anatomically there'll be a difference between the male and the female breast.
Okay.
So that's the second stage of development. And then now it's completed when they get babies.
Okay.
And now the milk production can start, because ultimately that is the function of the breast.
Oh, the breast eventually,
so when so different hormones come into play, so that once they are pregnant and they deliver and they start breastfeeding, then the breast cells undergo that last stage of development.
All right.
So it is said that before they get to that last stage of breastfeeding, then there's a slightly increased risk of getting that breast cancer.
Okay.
Yeah, at a cellular level.
Okay, yeah, because I'm trying to imagine all those things. Dr. Nasitna, very quickly, so we talked about self-breast examination. So when should we do it? How often should we do it? And how? If that is possible, because I see we have 5 minutes before we go on a break.
Yeah, so I think that's an interesting question. As Dr. Hungu was saying, that there are changes during your female cycle that happens to the breast.
Okay.
So even monthly, there will be changes to your breast. Most women know that during the period, the breast will become heavier, more lumpy. So examining at that point might be difficult. So it's better to do it after the period is done, where there are least changes in the breast. Patients with larger breasts will find it more difficult to examine their breast. So we encourage you to do it once a month. There are several techniques to doing breast exam.
Okay.
So you can employ a circular motion. So the first thing is to just look. The breasts are not going to be the same. You have, normally one breast might be slightly bigger than the other, one might be higher than the other.
Yeah.
And so you need to know, this is how my breasts look normally. This is normal.
Right.
So some of the changes in the breast when you have breast cancer could be one breast becoming smaller. So, you know, becoming shrunken. You can see the changes in the skin we were talking about. You can have dimpling. You can have the nipple going in. So first looking in the mirror and saying, this is how my breasts look. And then also just like raising the hand and then examining all parts of the breast. You can use a circular motion or you can use an up and down motion, and making sure that the armpit is also looked at, the underarm, you also examine that.
Yeah.
The other thing you can do is make sure you see a clinician to do a breast exam as well, and if you're over the age of 40, to do a mammogram. The reason we're talking about mammogram is you could have breast cancer that's very, very small. You will not feel it in terms of a lump, but when we do the mammogram, which is a type of X-ray, we could see early changes of cancer, such as calcification, and you could see a lump that is very small, which we might not be able to pick as clinicians, and you as a patient will not be able to feel. So that's the value of mammogram over clinical breast exam. So by the time you feel a lump, it's at least 1 centimeter, and a mammogram will pick something that's smaller than that.
Okay.
Yeah.
For someone who is interacting with the term mammogram for the very first time, okay, do you want to just tell us what exactly, because I hear it's painful.
It depends on where you're getting it done. So I think many people actually don't go for mammogram because they have this feeling that it's painful. But it's basically a form of X-ray for the breast. So the breast tissue is put between two plates, and then they are pressed, and that's the part that is uncomfortable, but it lasts like a very short time, and they take different images of the brain, of the breast. So then you have a qualified person, you know, like looking at them and saying whether this is normal or abnormal. And what Dr. Hungu said, when you're younger, even the 40-year-olds like myself, every time I go for a mammogram, I have to have an ultrasound because they say you have dense breast. We cannot completely say that there's nothing there. So many times you'll go for a mammogram, you'll be told to do an ultrasound. Sometimes they'll tell you do an MRI because they might be seeing something that is not clear, and they need more tests to look at it.
Okay. Yeah. And Dr. Hungu, do you want to speak on dense? Because when you say dense, a lot of people will think is the size of the breast, and what exactly does that mean?
So it's not exactly size. You could have small breasts that are quite dense. You could have large breasts that are not very dense. So the density is usually brought about by the glandular tissue. So the breast itself has several components. So there's a glandular part where the milk is produced. So that's the functional part. And then now there's a supportive part. So there's some fibrous tissue, there's some bit of fatty tissue. So when we say dense, is that the glandular aspect is more pronounced when you do the imaging.
Okay. All right. So Eunice, before we go on a break, we literally have a minute. Is it fair? No, let's just take a break, Johnson, if that is okay. Because I do not want to rush. You'll be like, in 1 minute, tell us this. All right. So let's take that break. But then when we come back, we'll really focus on screening. And this is as far as prevention of breast cancer is concerned. But like I said, any question that you have, feel free to send them our way at MTV Kenya, both on Facebook and on X, and tag me as well at Lubembe_Winnie, or you can, as well give us a call. Our lines are open, and we look forward to hear what you have to say as far as breast cancer is concerned. So see you on the other side of the break. We are on location. We are at the largest referral hospital in East African region. That is what I was told. And this is Kenyatta National Hospital. And we are in a theater. And like I said, if you've never been in a theater, then do not worry. We'll give you a feel of the same. And again, this is as far as breast cancer awareness is concerned. And today we're talking about treatment and care. And to help us with the conversation today, we have Dr. Eric Hungu, who's a general and breast surgeon. We have Dr. Sitna Mwanzi, who is a medical oncologist. And we also have Eunice Wanjira Njaramba, who is a breast cancer survivor, and we celebrate her today, and so many other breast cancer survivors out there who are watching us this morning. All right, and like we said, if you have any question as far as breast cancer is concerned, or you want to share your story as well, and this is of a family member or a friend, or if you survived breast cancer as well, feel free to share them with us on our socials at NTV Kenya, both on Facebook and on X, and tag me as well at Lubembe_Winnie. So before we went on a break, there's that question of, first of all, diagnosis and also treatment. And do all cases of breast cancer results in surgeries, okay? So we'll be answering that in a moment. But Eunice, you talked about support and how much of it you got from your friends and from your family members. But we all know how, like cancer can be very straining, especially when it comes to financially. So I'm just curious to understand, how was that for you? Did you have like some form of cover, and if so, how much was it, as far as to cover your diagnosis of breast cancer, before we talk about treatment?
Okay. When I was diagnosed, I had, back in, maybe I can go back to 2011.
All right.
I was retrenched from the former employment I was in.
Yeah.
And it was so bad, such that we were not paid. Maybe we were only paid a third of our dues. And to date, we are still fighting for the same. So when I was diagnosed with cancer, I did not have an insurance, and maybe we only had NHIF, and maybe they could not cover everything that was supposed. And you realize even when you are going for screening, it doesn't cover, so you have to look for the money. So it was not a good experience. So what happened, maybe now when the tests, we just tried to look for money. We tried it, we got the money for the screening. Then about the surgery, the NHF was giving just a small part of it. Then the rest we had to get it from friends and family. Yes.
Okay. All right. And Dr. Nasin, I'm asking this because, is this one of the biggest gaps as far as, addressing and preventing and just, treatment of cancer is concerned?
Yeah. So quite a number of people do not have insurance cover. And we also know that our NHIF coverage in the country is still very low. At least here in Kenyatta, the NHIF is covering for mammogram. So if you have NHIF cover and you need to do a mammogram, you can come to a hospital and you can get it done without paying for it if your NHIF is active. So one of the things that people do is they don't have NHIF for the longest, and then they become sick, then they start paying for NHIF, and NHIF does not become active immediately. So this is just to encourage people to get on board because it really helps. Whereas before NHIF wasn't covering for many things, right now it covers for quite a bit of the surgery, it covers for quite a bit of the chemotherapy, and covers for radiotherapy as well. So that has really improved in the last 5 years.
Okay.
Yeah.
All right. And of course, there's a lot of conversation surrounding universal health coverage. The president's going to launch that tomorrow.
Yeah.
So how much of an impact will this be as far as the fight against cancer?
I think for me, it's still an unknown, just to be honest. Maybe I haven't done my due diligence, but it's still an unknown because it's not something that's been rolled out for us to see, yes, this is going to impact. We are hoping that everything is being done is going to be for the good of the public, because actually people are out there suffering, especially if you have a chronic illness. The burden can be quite high on the patient and the family and the community. So we are hoping that those are some of the things that could be sorted out when we have universal health coverage.
Okay. Dr. do you want to contribute to this? I mean, especially when it comes to human resource, and also the state of our healthcare facilities and what needs to improve so that we sort of like win this fight against breast cancer or any other type of cancer.
So in terms of resources, we can talk about the capital investment sort of things, like the screening tools, the mammograms and CT scans for staging and such things. Okay. And then there's the human resource aspect of it. So in terms of the mammograms, I know there was the MES program that was equipping the county facilities. So at least we know, I think it's all the counties have mammogram machines. Okay. So that makes it easier for people to access the screening facilities. And then when it comes to reporting those mammograms, I think there's a way they're linked to a PACS system. So that's like an online cloud sort of thing. Right. So that some of the radiologists here in Kenyatta, I know Kenyatta is linked to some of those counties. Okay. They would be able to assist with some of that diagnostic, the procedure. Okay. And then in terms of now, when it comes to treatment, the personnel aspect, so of course it's usually not a one discipline or a one team kind of management thing. So that's why you have Sitna here in the oncology team, then you have the surgical team, and then now you have the rest of the team that's involved, the radiologists, the pathologists, you have to have the nursing component of it, which is very important. You need physiotherapy, you need nutritionists. So it's a whole big team. So these people are available.
Okay.
But now the challenge now comes to the numbers of maybe the oncologists.
That we have
but
in the country.
The number has improved.
Okay.
Because there are training programs locally, and I know previously the ministry was also facilitating people to go abroad to train so that they can come back and build capacity.
Okay.
And then now we have the universities that are training surgeons, because at the end of the day, the most commonly performed surgery for breast cancer is a mastectomy.
Okay.
So that can be done by any qualified and competent general surgeon. It doesn't necessarily have to be a breast surgeon.
All right.
And then now when it comes to now breast surgeons, so that number is a bit smaller, and they are mainly located in the bigger facilities.
Yes.
There's one in Kisii, then majority are here in Nairobi.
Okay.
So the utility of the breast surgeon would be when it comes to doing some more complex type of procedures, you want to give a more cosmetic outcome with a good outcome also in terms of treating the cancer.
Okay.
Yeah, but
all right.
the bulk of the work can be done out there. But again, it's not one team running the show.
Yeah.
So multidisciplinary. And here at KNH, we usually have a weekly multidisciplinary meeting. And it's not just for KNH patients.
Okay.
Because now with COVID, we learned that we can do things virtually.
Yeah.
So we get people logging in from the counties, and they actually come to us with their complex and their challenging cases, and it's all teamwork.
I see that. All right. Doctor, do you want to speak quickly on the different treatment options? Because we usually talk about chemotherapy, radiotherapy, surgery, but there's also brachytherapy. I'm really curious to understand whether we're doing that in the country at the moment. But do you want to just speak about the kind of treatments that we have, options? Yeah.
So breast cancer treatment depends on the stage of breast cancer. So if you talk about the most commonly asked question by patients when they come to the hospital is, what is the stage of breast cancer? So Eunice has said she had stage 2 breast cancer.
Yeah.
The way we do the staging is by looking at the size of the tumor in the breast, the number of lymph nodes that are involved in the armpit, and whether the disease has spread to other organs. And that's why patients will be sent for extra tests like a CT scan or a PET scan. So the early stages, stage 1 and 2, most of the time we will discuss in the meeting, and that's quite important to discuss in this multidisciplinary tumor board meeting. We look at everything, and then at the beginning we decide that this is what we are going to do. The other thing that determines treatment is the type of breast cancer. Not everyone has the same type of breast cancer. We look at some signatures on the cancer cells that determine whether your tumor will be hormone positive or something called HER2 positive, or all of them are negative, so triple negative. So a lot of the treatment will depend on the type of breast cancer that you have. But if you're looking at big blocks, the main treatments are surgery. And the surgery, I think Dr. Hongo can explain the different modalities of surgery. And then we do chemotherapy, and not all patients will require chemotherapy. So chemotherapy, where I work, we use drugs that we know kill cancer cells, and there are different drugs for different cancers. So for breast cancer, there will be different drugs. They won't be the same. Different patients might get different types of chemotherapy. And they're usually done in cycles, and if you get one today, you'll get another one either every 2 weeks or every 3 weeks for a predefined number of cycles. And then there's radiotherapy, which is the use of high-energy X-rays to kill cancer cells. And even in radiotherapy, there are many advances in how the radiotherapy is delivered, how the planning for radiotherapy is done. With regards to brachytherapy, the role for brachytherapy in breast cancer is not, I think brachytherapy is more like for prostate cancer and sometimes for things like esophageal cancer. So it's not a modality that we use in breast cancer.
Okay, but there's brachytherapy here in the
Yes,
country.
Brachytherapy that we are using here is mainly for cervical cancer.
I see. Okay. All right. So Eunice, you were told before we talked to Doctor about the surgery aspect of the same. So you were told surgery would be the best option. Okay. What is the first thing that comes to your mind when you think about surgery? Because for so many women, it's like, will I lose my breasts? Yeah. So what was the initial reaction when you were told you have to go through surgery?
Actually, that time it did not occur to me how it will be after.
Okay.
Because it was from the past experience with my relatives, I was ready for anything that will remove that burden from me.
Okay.
So that time I did not even think about how I would look after that.
Yeah.
So I was ready for anything. I did not want to waste any time.
Yeah.
So it was okay with me.
Okay.
Yes.
All right.
And according to the way he explained to me, I was at rest. I was ready for it.
Yeah.
Yes.
And that's a good thing to hear, because a lot of people are really scared, to even think about surgery. But doc, so then what is that process like? Who qualifies for surgery? Who does not qualify for surgery? If that's the thing.
Okay. So like Sitna said, not all patients will qualify for chemotherapy. So therefore, not all patients will qualify for surgery.
surgery, yeah.
When we talk about breast cancer management, it's usually on a case-by-case basis.
All right.
And that's why when we do these multidisciplinary meetings, we have to discuss each patient.
Okay.
And when we are discussing, we are taking into consideration the tumor characteristics, the stage,
Okay.
and then we also have to take into consideration also what does the patient want. So like if it's a stage 4 breast cancer, meaning it's spread to the other organs, then most times you might find that surgery might not have a role. But again, this is on a case-by-case basis, because it depends on which organ it has gone to.
Okay.
And then now when it comes to surgery, so like Dr. Sitna had mentioned earlier, sometimes patients come to us with quite a large tumor. Sometimes it's ulcerated. So when we are going for surgery, we need to be sure that in terms of treating the tumor, the cancer, that we are safe. Okay. So we don't want to go for surgery and cut and leave some tumor behind. So that's the first thing. We need to know that we are removing everything. So if the tumor is big and we are not confident that we'll be able to remove everything and be able to close our incision, then we can start with chemotherapy.
Right.
So the chemotherapy can sort of reduce that size. And then now we can proceed to do safe surgery once they're done with chemotherapy. But then also you might find that some patients want a more cosmetic outcome. And like Sitna said, we're getting a lot of younger and younger patients coming to us.
That's true,
so people in their 20s, people in their 30s, even some ladies in their 40s. So that's also one of the considerations they have, and that's where now, again, that multidisciplinary aspect comes in. Okay. So as a breast surgeon, I can do some of those oncoplastic procedures, but sometimes they need a more comprehensive reconstructive surgery. So then the plastic surgeon comes in.
Okay.
Yeah.
All right. Do you speak on mastectomy? So people really understand, because again, like I said, a lot of people think when you talk about surgery, it's like complete removal, but that is not always the case.
Yeah, so surgical options, there could be the mastectomy.
Yeah.
So there's the traditional mastectomy, which is what is the most commonly performed procedure still. It's what has been done for years. But now we are getting new techniques, new methods. There's what we call now a conservative sort of mastectomy, where you can remove. So when you do the traditional mastectomy, you remove all the breast tissue and the skin and the nipple, so that at the end of it, when you finished closing up your incision, it's flat. Yeah. So that's the traditional mastectomy.
All right.
The more conservative techniques, there's a skin sparing or a nipple sparing mastectomy. So this means that you position your incision in such a way that you're not removing the whole skin of the breast. Right. And depending on the particular tumor, also talking about the location, you might also be able to spare the nipple. So it's sort of like you're going under the skin envelope, then you remove the breast tissue, and then sometimes you need to make a separate incision to remove the lymph nodes in the armpit. And then when you do this type of mastectomy, then it is usually paired with a reconstruction. So the reconstruction can either be in that same sitting or it can be later. And then the reconstruction can be two forms. You can either use an implant or you can use your own body tissues.
Yeah. All right. I think some other time we'll talk about this implants and see the different types and what usually happens. But so then what does post-treatment, honestly, I don't want to say just post-surgery, but they say the treatment's care look like when we're talking about breast cancer?
Yeah, so I mean, post-treatment care is long-term. We usually see these patients for up to 5 years, sometimes longer than that. And it really also depends on the stage. So the post-surgical care is usually done by the surgeons, but we also participate in that because patients can have pain along the scar. They can have swelling on the arm because of the surgical changes that happened. So there is that. Most patients will be on a form of treatment after, especially the hormone-positive breast cancer. They might be on a pill for about 5 to 10 years. So we see the patients quite frequently. The first 2 years, we keep a close eye on the patients because the risk of the cancer coming back is usually highest in the first 2 years. And then after that, so initially we'll see them maybe every 3 months for the first 2 years, and then we'll make it every 6 months for the next 3 to 5 years. The other thing we do is that we do an annual mammogram for the other breast to make sure that there is no cancer coming up, because once you have breast cancer on one breast, there's an increased risk of getting cancer on the opposite breast. So then that's the reason now we will be doing an annual mammogram for the remaining breast. So there's also the psychological support that is needed. Even some of the treatments that we give after, they can have side effects like a bone pain and, psychological changes. There's also issues about sexual dysfunction, and then women who are in the reproductive age will have concerns about fertility, because some of our treatments like chemotherapy may have an impact on fertility. So that's an important discussion to have with patients.
Okay.
Yeah.
All right. Eunice, so what was that journey like for you? So after your surgery, and just taking care of yourself, and at what point were you, declared you are on remission?
Okay, the journey was not so sweet, because you realize now after the surgery, this part of me that is missing. There's no balance. So it was not very easy, but with the support, maybe from the doctor, and even from the family,
friends, yeah.
and yes, and then someone referred me to a group, women group, a group of cancer survivors. So we were able to encourage one another, and we were able to look for ways of balancing. Yeah, so we looked for, there's something that we make, they are called prostheses. So we are able to make them, and then we put them where the other breast was removed. And you cannot, now I know you can't even know which one is missing. So it has been good because of the support. Yes.
I see that. I see that. Okay. So like we said, we were focusing mostly on screening because we want to, again, prevent as much as we can. So what exactly does that look like? I know we talked about self-breast examination. Is that also considered part of the... that you're there? Okay. All right. So what is that? Yeah. Okay. But what does that look like?
So screening basically means that we are taking people who don't have symptoms, who are healthy. Okay. And you need to check them to see whether they have early disease or not. Okay. So it's done in the normal, healthy, asymptomatic population. All right. So the Ministry, of course, the Ministry of Health has developed screening guidelines. It's a booklet. So it gives recommendations as per age group on what is the recommended screening and the timing of this screening. Okay. So from age 40 going on, it's recommended that you get a clinical breast examination with a mammogram. All right. Every year. So from age 40 to age 55, you do that every year. All right. But you don't have to wait for the 12 months to be up. Because when you come to the doctor or to the healthcare worker for the clinical breast examination, they will show you the correct technique of doing a self-breast examination. Okay. So that is also a very important aspect. Okay. Because we can't just leave health to the healthcare workers. We also need to take responsibility so that if it's not yet time to come back for your screening and you're doing your self-check and you notice something unusual, you don't have to wait for that time. You can always come back to hospital. Okay. So from age 55 to age 65, 75? 75. Okay. It's every 2 years. Clinical breast examination and a mammogram. Okay. So most of our patients still opt to continue the annual, no harm done. Okay. And then from age 75, it is as per patient preference. So some patients will opt to continue annually. Some will say, will come as per requirement. Okay. Now below age 40... I was about to ask this, what happens in this group? Okay. Below age 40, so from age 35 to 40, there's you do the annual, and you also do an ultrasound. And then there might be a role to play for a mammogram, in case you might find something unusual on the ultrasound. So that would not be a screening mammogram per se, it would be like a diagnostic mammogram. So those are different things. And then below age 35, you can go every 2 to 3 years for clinical examination with an ultrasound. But there are also considerations as to what category of the population you fall into in terms of risk profiling. Because some people will be high risk population, some people will be average risk. So majority of people are average risk. So high risk would be someone who's had a family member or two, first degree family members with previous breast cancer. So first degree is either a parent, a sibling, or a child. You might have had previous breast cancer. You might have had previous radiotherapy for some condition on the head and neck. And you might have had previous lesion that was seen on imaging, which on biopsy was not cancer, but there are some sort of benign lesions, benign lumps, that might increase your chances of developing breast cancer later. So for those people, some of them might actually be younger than 40. Some of them might be in their 20s actually. And a mammogram and an ultrasound might not be of too much value. In such patients, an MRI would be recommended.
I'm just curious, for the men, then what does that look like? Are they also encouraged to go for screening? And then there's also this thing about fear of the unknown, right? What if I go and then I'm told that I have it? So I'd rather not. I really want you to speak on this, but also speak on the men as well.
Yeah, I think the thing about fear, she has already mentioned it. She's living proof that if you are unwell, you go to hospital, you can get care, and you can get better. Because this is now, what, 5 years later. So people should know that knowing is actually in power, because you can do something about it. If you don't know, you won't be able to do anything about it. So I mean, screening for men is actually, like Dr. Hungu had mentioned, men have very little breast tissue. So by the time something is happening, they'll be able to pick it up earlier. I'm not aware of any screening guidelines that are there for men. So usually for men, it will be, you have a symptom, you go and you are told whether there's a problem or not. But we shower every day, I'm hoping, so you can easily, at the very least, you can check your breast as you shower. We actually have men with breast cancer. People, I wish we had come with a male breast cancer patient so that people can see that it's actually true. They can be young. Most of the time they're more elderly, but you can have young people with breast cancer, and they actually present with a breast lump. So these things actually happen.
Then what is it that we can do to prevent cases of recurrence? Because we've also seen that. And then one of the questions that people ask a lot, and I know doctors are very careful to answer this, and that is, so why is it that someone goes through chemotherapy, radiotherapy, maybe surgeries, and unfortunately still die?
I think all the treatments are aimed at reducing your risk of the cancer coming back. So I didn't say eliminate, I said reduce. Because like you rightfully said, you could have done everything and it still comes back. But that goes back to what was the type of breast cancer you have, the biology of your cancer. So there are some types of cancer we know have a higher propensity of coming back, and there will be treatments to try and reduce that as much as possible. But this just tells you that there are just so many things about breast cancer and other cancers that we don't know, because we've given it our best shot and still something happens. But even if the cancer comes back, there is still treatment that's available. It shouldn't be that people should not come for their initial breast cancer because it's going to come back anyway. You don't know which part of that divide you're going to lie in. We have a lot of patients. In fact, today we have a clinic for just people who've been treated who are coming for follow-up. So we have loads and loads of patients who have been treated successfully and have not had a recurrence. Even those who have a recurrence, we're still taking care of them.
All right. And I think that's what we're saying. Screening is very important, you know, for as much as you can. All right. Just go for screening at least once a year, they say. So we need to end the show in the next like 4 minutes or so. So Eunice, I want you to speak to the people who are watching us this morning and thinking, okay, I want to go for screening, but I'm not too sure, you know, what if I am told? And also people who, you know, still a lot of myths and misconceptions surrounding breast cancer. What is it that you will tell the general population and also cancer survivors as well?
What I can say for the general population is that to take advantage of screening, and especially this month, October is usually a breast cancer month. And you can also even go for screening even for the others. Please take advantage of this month, and love yourself such that you can set a day, maybe a day in a year, to be getting to be screened. Because the earlier you know, if you have a disease, the earlier you know it, the better. There's a more chance of treating and maybe being victorious. Because like mine, I know I am this far because it was discovered early. So it is important, everybody, whether you are a man or a lady, it's very important you be screened. And then for those who will be told they have cancer, it doesn't matter what it is. It is not a death sentence. There's still a solution. God is there. And once you present yourself to the doctors, there is a solution. And mostly be positive. Because I remember when I was told I have cancer, being positive really helped me. Because I was always confessing, I will not die. I am living to declare the goodness of the Lord. So even how you take it is very important. Because some people get shocked. They are not even ready for the treatment. They are not even ready for drugs. I remember this lady I was told she refused even to take drugs and she died. So it's good to take it positively and get help. Even if you don't have money, just take it positively, present yourself to the health center. And wachie mengine Mungu.
Yeah, that's true. That's true. Okay, we like the positive aspect of the same. Positivity and attitude. All right, Dr. Sitna, what is it that you tell the people?
Yeah, I think Eunice has said go to the hospital.
Okay,
also, healthcare workers are really prone not to go for screening. So to my other healthcare workers who are out there, please go for screening as well. You as a clinician have to take care of yourself. So everyone needs to go for screening. There's age-appropriate screening. Screening is available here at KNH. A mammogram will be covered by NHIF. We are here to take care of you, whatever the stage of cancer you have. So if you're unwell, please come to the hospital.
All right, and screening is ongoing at the entire month of October here at KNH.
Yeah.
Okay, all right. All round. Okay, but there's special emphasis on October. Okay, Breast Cancer Awareness Month. Okay, so we are in your territory, theater. So do you want to just give us a feel, literally, so a feel of what, because there's so many things here. Like I said, came in here and got a different feel, and so what is all this as we wind the show? Yes.
Just an overview. So of course there's a theater team that knows all these things in there.
Yeah, they're actually at the back. You can't see them, but yes.
But of course you have the operating table. It's adjustable. It can go to different heights depending on the height of the surgeon or the operating team and exactly what you're trying to access.
All right.
It can tilt side to side. This is the anesthetic machine. This is where the anesthetists do their thing and allow us to do our thing.
Okay.
So that's a ventilator and the monitors. And then, so when you look on that side, there are some gadgets. So those are like the energy devices because, of course, when you're doing our surgery, we want to minimize bleeding. So that would be called cautery. There's some other types of energy devices that we utilize to help us make our surgery a little bit easier.
Okay.
On that side is a suction machine, so it can be used to suck away the so when the energy devices are in use, of course, they can produce a little bit of smoke, so you need to suck that out. And then when you're done with the surgery, some surgeries you might need to do what we call an on-table lavage. So that means you're washing sort of our solutions. So that suction is useful for trying to suck away that fluid that you've used for doing your on-table lavage.
Okay.
It's also useful for the anesthesia team when they are waking the patient up from anesthesia. There are a lot of secretions from the airway. So if we're not careful, that can cause some aspiration. The patient might choke. So that can be useful for suctioning away those secretions.
Okay.
Yeah.
All right. And of course, we have to drape in this beautiful, yes. Okay.
And these hairnets.
Yes. So what is it that then you will tell people who have, this fear as far as, theater and surgery and all those things are concerned? First of all, the slides are too hot. But nice, okay. Yes. But yes, what is it that we can do to sort of change that mentality as we literally end the conversation in 10 seconds? It's not enough, but try.
So I think at the end of the day, we do our best to try and communicate to the patient, to try and put them at ease. So of course people have different personalities. Some people will be more prone to anxiety, some people are not. So as part of our management, we also recommend some counseling services, some psychologists to take a review. But at the end of the day, before we bring in someone to surgery, we do what is called an informed consent. So we have to explain everything that we intend to do, and they need to understand.
All right.
And then usually I have them just say it back to me to see how they've understood
how well
so that we know that we're on the same page.
All right.
Yeah.
Okay.
So that is what we can do to try and make someone at ease, comfortable, but really we can't do too much beyond that. So the rest is like Uni said, her attitude was very positive.
Yes. Yeah.
So that's the main thing.
Yeah. Okay, all right. But for now, we have to say goodbye. So much to cover. But we have to say goodbye, Dr. Ekungu, General and Breast Surgeon. We had Dr. Sitna Mwanzi, who's a medical oncologist, and not forgetting Eunice Wanjira Njaramba, who is a breast cancer survivor, here to share her story. So thank you so much for your time this morning. We've learned a lot, and we hope that you've also learned a lot as far as breast cancer is concerned, because remember, over 3,000 people, all right, are dying from breast cancer, and that makes it the second leading cause of cancer deaths right here in the country. So that means about 7 or 8 women are dying every single day, and that should not be the case. So let's do as much as we can to prevent. Go for your screenings as well, very, very important, so that we know what exactly we're dealing with. So we'll continue with the conversation online, and that is on our socials at NTV Kenya, both on Facebook and on X as well. But for now, right here, we're saying goodbye on your world. Have yourselves a lovely day ahead, and please go for screening. My name is Winnie Lubembe. See you tomorrow.